They say life is easy when you've got a good head on your shoulders. Hi, everyone, and welcome to They Say It Takes a Village. On today's episode, I'm joined with the lovely Yasmine Crane, or as she's famously known as the Baby Physio DXB. Today, we're going to be talking about plagiocephaly, or as we know it as flathead syndrome. How to diagnose it, how to prevent it, and how to treat it. So without further ado, Yasmine, welcome to They Say It Takes a Village. It's such a pleasure having you on.
Thank you so much. I'm very excited to be here.
I'm excited to have you. Again, thank you. I know you've got a little bit brand new baby and a life and a full-on thing. And it's, I don't know if you guys know, this episode's recorded while we've got massive rains outside.
Yeah, I can hear it.
So we've managed to squeeze it in before we get flooded.
Yes.
So thank you for coming and making the time out.
Very welcome.
Do you want to tell the listeners a little bit about yourself?
Sure.
How long have you been in the UAE and what you practice?
Sure. So I've been in the UAE for 17 years on and off. So I went back to the UK to study where I'm originally from.
Yep.
And most recently I came back in about 2018. So yeah. I am a pediatric physiotherapist and I specialise in children with neurological conditions.
Okay.
And I have a very special interest in plagiocephaly and torticollis. My son had brachycephaly, which we'll talk about, as well as plagiocephaly.
Yeah.
So that's kind of really sparked a big passion project from me. I'm trying to get the word out there as much as I can and educate parents because it can be preventable. So we are going to.
That's good to hear. And also, it's you hear that word and it's a bit, I don't know, nerve-wracking.
Yeah.
I don't know. It just seems a lot more serious than it potentially is, or the fact that you can prevent it. That's brilliant.
Yes.
So I think probably the biggest and first question is, what is plagiocephaly?
So plagiocephaly is just one of these.
I keep trying to rehearse that word in case I'm saying
it's a mouthful, isn't it? Literally, it derives from Greek and Latin. So plagios, which literally means oblique slanting, and cephaly, which means head. So that's what it is. So flathead syndrome. Yeah. It's basically, plagiocephaly is a flattening on one side of the skull.
Okay.
And depending on the severity, you can see some other attributes with it as well.
Okay.
But in its kind of defined term, it's flattening on one side of the head.
And how are babies just born with it, or how does it come about?
So I think it's really important to touch upon the anatomy of the skull, because you think of a skull as one bone. Yeah, absolutely. Right? But actually in babies, there's about 5 bones which are joined together by these fibrous soft tissues, which we call sutures. Yep. It's really important to have these sutures, because when you think about the birth process, the baby's head needs to be super flexible to be able to come through the birth canal. That's right. These sutures don't actually start to fuse until about age 2. Oh. So that leaves us with these babies that have got super kind of malleable, flexible head. And there's mechanical factors. So if you think of a new baby that's kind of placed down in one position, and for whatever reason they are prolonged in that position, you're going to start to see some flattening, some restriction of growth in that area. Yeah, so we've got such rapid growth in the first 2 years of infancy. Yeah. Again, coming back to these sutures, they're like an extendable joint. They allow for that rapid growth. So when we restrict one part of the brain, of the skull. When we restrict one part of the skull, the brain is going to grow, and it's going to push on. It's going to push on another area. So you're going to end up with an asymmetry.
Yeah. And is that, a lot of the times, again, is that in line? Have you seen it happen more these days? I know we have a lot of these things. Obviously you have guidelines as to how to put your baby down, and it should be, sort of this back-to-back type of.
Absolutely. So that is so important.
Yeah.
So important that you're putting your baby back on their back to sleep.
Yeah.
So the number of plagiocephaly cases have definitely risen since early 1990s, where the back to sleep campaign came in. So we know that putting your baby on a firm surface on their back is reducing the risk of sudden infant death syndrome, or SIDS.
Yeah.
So we know that, and that's absolutely non-negotiable. We have to do that. Yeah. That does increase the risk of plagiocephaly, and I think it does get a lot of the attention for why the number of plagiocephaly cases are on the rise, but there are other factors that you need to think about as well. Yeah. So, for example, the advances in healthcare, you've got premature babies that are surviving that are being born younger age. Yeah. So this can increase the rates of plagiocephaly as well.
Oh wow, I never even thought of that.
Yeah. So
that's amazing.
There's a lot of things, but also it's a lack of education. Yeah. I think we need to do better at getting this information out there, because you do, when you're expecting a baby, you might do your hypnobirthing, you might go to these prenatal classes. And I never was taught, I know about plagiocephaly, but it wasn't once brought to my attention during my pregnancy or any of the education around that.
To keep an eye on it.
Exactly.
To consider it,
and how to prevent it. Yeah.
Are there different types, or like, is there, for example, like mild, moderate, severe?
Yeah, absolutely.
Oh, okay.
There are. So there's 4 different types of head shape. So we talk about plagiocephaly as the most common, and that's your flattening on one side of the head. That comes in mild, moderate, and severe. Okay. So you have to think of the head as a 3-dimensional shape. So if you've got flattening in one part, you're going to have what we call like a parallelogram shape.
Oh my goodness.
So you're going to have some changes in the front part of the...
kind of overcompensate.
Exactly. Yeah. So from a mild case, you'll just have the flattening at the back, and then your more moderate to severe cases, you're going to have ear misalignment, maybe eyes are going to be asymmetrical, your jaw, and the front of the head as well. So it varies.
It changes the entire shape of your face and head.
Absolutely. So that's plagiocephaly.
Okay.
Then you have brachycephaly, and my son had this. So brachycephaly is the flattening of the whole back of the head. So you'll see a widening at the back of the head.
Got it. So that's brachycephaly.
Brachycephaly, yeah.
Okay.
Slightly higher cranial vault, we call. So the top of the head is going to be higher with potentially a slope coming down. Yeah. Forehead bossing, so more of a squared forehead. Okay. And again, that varies from mild to severe. Okay. You've got brachycephaly with the plagiocephaly.
Gosh.
So that's where you've got the flattening of the back of the head, but also an asymmetry on one side as well. Yeah. And then we have what we call scaphocephaly. This one is where your head is abnormally narrow. So you're flattened on both sides of the head. And it's more common in babies that are admitted to the NICU because of the positioning. So all of the medical treatment that they're having, they are positioned on the side of their head. So the growth then is restricted on the side of the head. So there's lots of different types of head shape.
And you can't really decide which one it is until you've had a proper assessment, can you?
Yeah, so assessment, you can kind of classify what type of head shape you've got, a flathead syndrome.
Yeah. And do you see these at different, is it, so let's say, for example, the baby is born, a month later, is it evident then, or is it a bit more, so as they get a bit older?
So you can have, so with plagiocephaly, you can actually develop this when the baby's in utero, so in the womb.
Can you?
Yeah. So it depends on the position of the baby. So breech babies are more likely to develop it.
Gosh.
But also if you've got a multiple pregnancy, so twins, triplets, or any more than that, because of the crowding. So if there's crowding inside and the baby's head's being exposed to these external pressures, then baby can be born with a plagiocephaly.
Gosh.
So some parents may notice it at birth. Also, if you're in prolonged labour, you may see that flattening of the back of the head and that almost cone-shaped head.
My son Laith, my first son, he had like a bit of a cone shape, but it kind of rounded out.
They're the types that actually do start to progress on their own.
But sort of get better
on their own around about 6 weeks.
Yeah.
So with the plagiocephaly that you develop after birth, so postnatally, parents and caregivers tend to notice this around 6 to 10 weeks.
Okay. So when they've been placed down and, that type of thing.
Yeah, so, and it's almost like an overnight thing. A lot of parents say to me, I just feel like it wasn't there yesterday, and it's, I've noticed it for the first time. And I think a lot of the time it's when someone else is holding your baby, because you're holding your baby a lot of time, and you sit back and you think, hang on, what's going on with their head shape? So it's around 6 to 10 weeks that they'll notice that something's developed.
Oh, okay, good to know. Good to know, because definitely I remember thinking, gosh, his head shape is a bit weird, but this was straight after birth. And then my mom was there, and so I'm just like, oh no, that's normal. It will round out.
Yeah.
And I asked the doctor, I'm like, is that okay? Like, he's got a bit of a cone head going on. They're like, no, that's just had to squeeze down that birth canal. So it's funny, head shapes, and you think everybody's got a different head shape, but you would never and now sort of looking back at it, you're probably thinking, oh, that's, some adults have a bit of a
absolutely
portion on their heads.
I think as well, it's important to say that very rare that someone will have a perfectly symmetrical face. We've all got these little, I've got an eyebrow lower than the other. They say
I've got a nostril that's bigger than
I do too. But they say, eyebrows should be sisters, not twins, and mine are more like distant cousins at the moment.
They look perfectly. They look perfectly symmetrical.
But a symmetrical face shape is not very common.
No. So,
gosh,
it's all part of being a human, right?
It is.
I wanted to ask you, what is the risk? Are some babies more at risk developing Plagiocephaly?
Definitely. So we touched upon the crowding in the uterus, so twin pregnancies, prematurity, and also, I don't know why, but research has shown that firstborn children are more at risk of Plagiocephaly, and boys. So my firstborn child is a boy. There's also children that have torticollis. So torticollis, I won't go into too much detail, but it's basically the tightening of the neck muscles on one side. So you typically see a child will tilt their ear towards their shoulder and they'll rotate their head the opposite way. So they are restricted in their movement. So what you see is their prolonged position on the back of their head on one side. So they often come hand in hand, torticollis and Plagiocephaly.
So how, let's say you've got a parent and they're worried about the shape of their baby's heads. What would they do? How do they come in? How is it typically diagnosed? Is it just a matter of look at their heads and you kind of feel around for it? Or is there
first port of call generally is that you'd have a chat with your pediatrician. And hopefully if you've got a very proactive pediatrician, they will say, go and have an assessment with a pediatric physiotherapist. That hopefully is what's happening. I do hear, unfortunately, still a lot of time that parents say, well, I mentioned it to my pediatrician at 6 weeks and they said it will correct itself once your baby starts sitting, or it will round itself out. And unfortunately, we know that this is not the case. This doesn't happen. To correct any asymmetries, you need to apply counter pressure. It's not just going to correct itself. The brain does not grow and say, oh, do you know what? I need to fill out this part of the skull. It just grows, and it will grow
in whichever way that
in the path of least resistance.
Structure has given it way to.
So that's what will happen.
And that ranges again. So basically, from potentially birth all the way to 6 months, something like that.
So ideally, we need, as a physiotherapist, I can only be effective with my treatment up until a certain age. So the earlier the better. And again, I'm hoping to work with a lot of pediatricians in Dubai to get that information out there. As soon as you notice that your child has an asymmetrical head shape, flat head, reach out to either your pediatrician, and if they do not want to do anything about it, or they tell you not to worry about it, get a second opinion, or just come straight to a pediatric physiotherapist.
Again, it's a question I had down the line, but is it, I think we'll talk about, preventing it. Is it something to keep in mind that you can, anyway, I'll ask you that a little bit later, but just to maybe prevent it from happening, is that probably better than coming in when you feel like you've noticed a bit of a flattening on one side of the head?
Yeah, absolutely. So the education is the most important part, and I'm really pushing to kind of plant myself in some of these prenatal classes, doing coffee mornings and talks to pregnant ladies
to get the word out. It's really important
because I think it is very important to mention though, it's not always preventable.
Okay.
So we spoke about the positioning in utero. We can't do anything to prevent that. Also, back to sleep. We want our babies on their back to sleep. So these are they're factors that we cannot prevent. But the education around the things that we can prevent, that's where I'm trying to kind of push that information.
Just to kind of take you back, let's say you've got a patient that's come in and they've got a flattening on one side of the head, whether it's one of the many cephalies which you've mentioned, and pardon my ignorance, is that typically where you would fit them in for a helmet?
So helmet therapy is done by an orthotist.
Okay.
Yeah. So basically, my mission right now is to try and keep as many babies out of helmets as possible.
Oh, I thought that was just part of the treatment.
So helmet therapy is very effective and should be started around 6 months. Okay. Physiotherapy can be extremely effective, and I've seen corrections of asymmetry in a week with some of my patients. But we need to start it ideally 2 months, 3 months.
That's early.
4 months, but you're pushing it. 5 months, it's starting to get too late. And that's because your baby around this age, their developmental milestones, they're starting to roll. They are over the 5-6 month mark. Absolutely. They're starting to sit. They're not staying still. No. To be effective with our positioning program, we need to apply that counter pressure. Absolutely. We need to have them remaining still overnight. We can't swallow the baby if they are showing signs of rolling. So that's where we're most effective with nighttime positioning. But also in the day, we want to try and keep them off of their, what I call the flat spot. And we want to have them over to the other side. So if it's a right side of flat spot, we want to put them towards the left. So all of our play, we're going to do side lying, we're going to do positioning, strategic positioning based on the child, based on what we see with our assessment. That's how we're redirecting the growth.
Gosh, that's amazing.
But we can't do that once they start moving around.
They won't let you.
They don't want to. They don't want to stay still. So that's when helmet therapy should be considered for moderate and severe cases. Mild cases, helmet therapy, there's no long-term risks of a mild plagiocephaly. Slight bit of a flat spot, but it's not going to lead to any of the asymmetries. However, in a small baby, if you notice that flat spot, even if it's very mild, still come and see a pediatric professional, because we need to determine what the underlying cause of that plagiocephaly is. If it's a muscle imbalance, which it normally is, we need to correct it, because that can then lead to a more moderate or severe plagiocephaly if we're not doing anything about it.
I feel like it should be just a thing. Have a baby and go see a baby physio.
I mean, I'd love that, because I love babies.
But I mean, because you can't avoid it. Because if you are, I mean, is there ever a situation where you have a baby and you've got this, they're sleeping on their backs and they don't get it?
Yeah, so it's probably seen in around 46% of babies. So the other 54%, no, there's absolutely nothing.
But 46% is a big
it's high, and that's what some of the research is showing as well. But other studies are saying it's more 20%. But it is on the rise. This is the concerning thing. It's on the rise. It's an epidemic, as I like to call it. So really, that education that we can get out there is so important. But not all babies need to come and see me. As much as I would love that, not all babies need to come and see me. It's only if you start to develop concerns about their head shape, come in, have a consultation, and we can kind of look at what's causing it and prevent your baby from having to go down the helmet route if that's what happens.
Which, I mean, I think is probably most ideal. I mean, having a helmet, I think they have to put it on for X amount of hours in the day.
It's 23 hours a day. It's very, very intense. I would also say, the babies are going down the helmet therapy route because we've lost that window of opportunity.
Got it.
Because they're not seeking, or they're being told to wait. Wait, see how it goes.
It'll be fine.
So that's why.
So let's say now that you said, let's say come and see me. What would you do? I mean, what is the role of a baby physiotherapist, for example? What would you...
The assessment.
The
assessment is the biggest part.
Okay.
We will look at what's causing this either plagiocephaly, brachycephaly. So in a majority of the cases, it's caused by a muscle imbalance. So we spoke about torticollis.
Yeah.
Some babies have a head turn preference as well.
Yeah.
So they may prefer looking onto the right side. Yeah. Once that flat spot starts to occur, it's so difficult to get your baby off that flat spot. If you think of a tennis ball with a slight dent in it, and you roll that tennis ball, it's going to land on that flat part.
Absolutely.
Right?
Just like anything. Yeah.
So it's more comfortable for the baby to lay on their flat spot. Then what that means is that's their preferred position now. You're going to have an absolute nightmare trying to keep them off it. So the assessment is very, very important. Then we work on education for the parents. And sometimes it's just really simple things, advice and education. Yeah. And the parents will go, I didn't think of that.
Yeah.
You know. So I will teach them how to position their child. We'll work on strengthening, stretching those muscles that need that extra bit of attention. Yeah. And then we'll start to work on their developmental milestones as well, because back to sleep and sleep safety, when you think about your child being on their back, once they can start to roll front to back and back to front, that's when it's safe for them to start choosing their own sleeping position.
That's right.
So ideally we want to get these babies off the back of their heads and either sleeping on their side, on their tummy, when it is safe to do so.
Yeah. I remember, my kids never had a sort of a flat spot, but my son had torticollis.
Okay.
We did a few exercises because, to be honest, I had no idea who to take him to.
Yeah, of course.
And somebody suggested take them to an osteopath.
Yep.
They helped a little bit. Good. And then he did have a preference, and then it went away.
Amazing.
And then, like you said, by the time 4 months or 5 months rolled around, he was kind of rolling anyway. And I felt like I didn't need to worry about that so much. And they do have pretty round heads. So
good. I
was quite happy about that. But I know that, again, a lot of people, or the recommendation at the time as well, when I was having my first, was do a lot of tummy time.
Yeah, absolutely. Yeah. So tummy time is an incredible thing to do with your babies from day one. Yeah. From day one, which is so many benefits.
Brand new baby. But the thing is, you've got them on your chest.
And that's tummy time. So when I say from day one, I'm not saying pop your baby on the floor on a blanket and off you go. No. So tummy time from day one is semi-reclined. Yeah. You're not laying flat and you've just got them over your chest. Yeah. And that's tummy time. It's beautiful.
Do you know that helped as well a lot with breastfeeding? Yeah. That was, again, a huge recommendation from a lactation consultant. Yeah. Just have them on your chest and then even have them potentially move to you know what I mean, to start to feed. So it was amazing.
Yeah, skin to
skin, and have them do sort of this breast crawl or whatever it is. I mean, moments after birth, but even when I think with the torticollis, that was another huge recommendation. Yeah, just get that neck muscle developed enough so that it's not preferring one side.
Yeah, because babies with torticollis, one of the kind of raising alarm factors for me is that parents will say, mums will say, they don't like to breastfeed on one side.
And that's exactly why. Yeah. And I was in so much, I mean, at the time, obviously, with just had a baby and you're engorged and it's like one side is fine and the other side is not. It was a disaster. But, as he also sort of grew a little bit, and then I was really hell-bent on trying to breastfeed, and we did it. But it was that worked, just to have him laying on my chest and have that tummy time. But tummy time in itself, they don't love it. And when they get a bit older and it's just a bit...
I would say there's normally a reason that your baby's not enjoying tummy time. So I've had so many parents say to me...
the face plant crying.
They say, my baby hates tummy time. And then they'll come to see me. I'll put their baby on their tummy and the parents will go, well, they don't do that with me.
It's true. Do you know, and I think it's probably you've got all the cool things that babies like, and all the little things that grab their attention for a bit longer.
Definitely.
Yeah, we need to get more creative.
We do a lot of work in physio on tummy time as well, and just educating parents that it doesn't have to be on the floor. You know, you can carry them over your arm, walk around, you know, give them a little bit of a bounce and movement.
I've seen parents now got them in the bassinet stroller.
That's me. That's me. Brilliant. I do. I take my little one out for walks. Not so much anymore because he's 5 months and he's starting to try and sit on his own. Yeah. But I used to take him out and I'd put him in the pram on his tummy, and it's almost like the movement of the pram, and he just tolerated it a lot more. And he really liked it.
It's really very sweet. You see these 2-3 month olds, you know, with their little necks going. Oh, it's so cute.
The other thing, just while we're talking about tummy time, I just wanted to touch upon, you'll read, if you do a quick Google search of how much tummy time should my baby do, and it says aim for X amount of time. I don't like that. I don't like that. I've never liked that as a physio, and I don't like it as a mum. Tummy time should be supervised when your baby is awake and alert, and it should be engaging and fun. So if your baby's screaming and crying, it's not nice for either of you, and actually it could cause an aversion to tummy time. So I always say work on tummy time when you've got those little windows where you've got a happy baby. You know, it may be for some parents that when you've done a nappy change up on the nappy changing station, that you just roll them in on tummy time. You're more at eye level with them, and you can have a little talk, a couple of minutes, and it's quality over quantity. So even if you're just getting a couple of minutes of tummy time and it's good quality, rather that than a baby screaming and crying and you say, no, we've got 15 more minutes of tummy time.
That's what they told me to do. It is. And I remember looking that up, like how much tummy time a day should my baby be having. And then there was like I remember this so vividly, there was a chart, like 1 month, 2 months, 3 months, and I thought, doesn't like it. But then what we did is, instead of on the floor on a blanket, it was just on our chest, like mine, which
is fine, and you can work up and build up to it. But you think of tummy time, you're off. It's an opportunity to be off the back of the head. So we do love tummy time.
I don't know. I liked it. I liked it definitely more with my second. With the first, I felt like it was something that we had to do. And I was just
drummed into you, isn't it?
I was
do your tummy time.
About tummy time, and it was almost like, did we get the tummy time in today? You know, and it's like, oh, calm down. Like, it's fine. You know, it's when he wants to do it. Just to go through, let's say, for example, long term. What happens if you don't correct it?
So there's a misconception that it will correct on its own. That's the first thing. Second thing, if it's a mild plagiocephaly, so just flattening at the back of the head, you don't see any asymmetries, any ear misalignment, there's no long-term effects. So you can just relax and don't stress about that, because it's so easy to work yourself up about these things. It's kind of super easy to correct at an early stage, but if you've missed that window of opportunity, don't stress about it. The more severe cases and the more moderate cases, then you start to get things like jaw misalignment. So you're thinking about your oral and your teeth, the way they develop. Your eyes may be slightly asymmetrical, which can lead to visual
impairment or whatever.
Very mild, but visual field disturbances. And also there was a study, I'm not sure how much credibility it's got, but the fact that more and more things are being picked up, that children with more moderate to severe plagiocephalies have got recurrent ear infections. It's very interesting. So it's all these things, but also if you've got facial asymmetries, the kind of psychological well-being of that child to have to grow up and potentially be bullied at school and
treated.
So they're the more long-term impacts of plagiocephaly.
And you mentioned in terms of self-correction, it generally doesn't.
No, if you think about, you've restricted the growth in one part, as we've already mentioned, you know, the head's going to grow, it's not going to say, I need to
fill that part up.
So the only way to correct it is by applying that counter pressure, which is treated by either repositioning or helmet therapy.
I'm just so curious, when you say the more severe, how can it get severe or that bad?
So it completely depends on a couple of things. If you've not picked up on it, some babies have really thick hair.
Yeah.
Really thick hair.
Hair. Okay, and you can't see it.
You can't see it. Okay. But also, you might have an undiagnosed torticollis.
Yeah.
So you, as a parent, you've got 1,000,001 things to think about.
Yeah.
You may not notice that your child is constantly sleeping on the right side of their head, constantly positioned on the right side of the head. They're looking at every moment in time on their back. They are on that part of their head. Point, And by the time you do realise, then it may be that it's got to a severe flattening, and you've got kind of the compensation coming across. You've got the ear asymmetry. So it can be as a result of that.
It's something definitely to think about. I never even thought about the hair. My kids were born completely bald, so I was able to scour their
You can see it. Definitely.
So but it's so true. I've got friends of mine who've got wonderful sort of full head of hair.
Yeah. And there is a trick for that, actually. If you did want to look at your baby's head shape and they have got that thick head of hair, is do it in the bath when their hair's wet and slicked down.
Oh, yeah.
So then you can have a look always from a bird's eye view. That's when you're going to see the flattening on one side.
So do you look at the back of their heads or the front?
From the top. So you have baby laying on your lap or over your arm, and you're coming in from bird's eye view with the tip of their nose up at the ceiling.
Yeah.
Then you can really see and take a photo and have a look.
And to see if there's any sort of
asymmetries that you'll be able to pick up on
that's
there.
That's a really good golden nugget right there.
Coconut oil to slick it down, or water.
Yeah, the coconut oil. Also, if you've got a bit of what was that thing called?
Cradle cap.
Cradle cap. Yeah, we used to do that too. Yeah. I wanted to ask you. So, generally, let's say, is this something that can be passed down? I mean, is it hereditary
No, it's purely a positional thing.
Yeah. So nothing to worry about genetically. Like,
no genetic.
My husband potentially has a weird shaped head, and my son's going to have the same.
No.
Okay, that's good. And risk factors for plagiocephaly. So
we spoke about the multiples, the risk factors of developing plagiocephaly. So it's those
these situations where they're in the
so in utero postnatally it's mainly positioning, and that's when it could be preventable.
That's the thing, and I feel like you said, it's really quite difficult for parents because you have a brand new baby and you've got so much.
It's survival.
On.
I've first 4 weeks for me was survival.
And the thing is, but you are concerned about everything. But I remember thinking, feeding was especially with the first. Feeding, not sleeping, changing, getting on with life, and it's a lot. And then you throw this in, but it's good that it's not as scary. I find that the name it's a bit more scary, but it's actually it's something that you can prevent. It's
Absolutely.
Easy. Even the treatment potentially is really, really straightforward. So it's really very
I'd be
important.
so interested for any child that was born sort of late 1990s, early 2000s and onward to scan their head shapes and see how many. I don't fit into that category, unfortunately. I was born in the 80s, but
I was definitely
I was on my tummy for sleep.
Me too.
Yeah.
And I think I have a pretty round shaped head, but I was on my tummy or on the side.
Yeah. So I'd be interested to see how many, teenagers and adults now, because they will be adults, won't they?
Yeah, that's right.
Have a plagiocephaly that kind of didn't go noticed or mild.
Gosh, and then you hear. I mean, you do a plagiocephaly flathead on Google. You get 1,001 suggestions for positioning pillows. Pillows with a hole in them, a pillow that's rounded, a pillow that's I don't know what, and it's promising that it will not give your baby a flat head.
Okay, slightly.
What are your thoughts on these pillows? Because I don't want to sort of obviously, these are companies that are making these things, but are they actually useful?
If you look at the FDA recommendation on these plagiocephaly pillows, it literally says, throw these away, do not give them to anybody else. They're dangerous. There's no research backing that they are effective in the slightest. And it goes against safe sleep. If you think about what
it should be an empty cot.
Empty crib, no pillows, no loose blankets on their back. So putting a child, and it's marketed, it says safe for
Absolutely.
sleep.
No, and
I don't know how they get away with it.
Flathead.
Right.
Yeah.
It's not going to prevent flathead. Firstly, you can't use it when the baby's asleep, and that's when we need to reposition the majority of the time. Secondly, if you're using it during the day, you're restricting your baby's head movement. Yeah. They can't turn their head fully right and left.
Because they've got this thing that's
They've got something blocking it. So I tell parents to get rid of these pillows. Don't buy them. Don't listen to it. It's very clever marketing, but sorry, I'm hated for it, but I absolutely hate these products.
But there's so many out there.
I know.
I even in my, when I was doing it, it's, you get on whatever site and you think, oh, maybe I need that.
Yeah.
Oh, that would be great. That's brilliant. I want to prevent flathead. And you don't know. And it looks so like...
I know.
This wonderful pillow. It's got memory foam and it's got I don't know what.
Yeah.
But
have a look on the FDA website and read their words. It's quite harsh. It's quite harsh. So
my goodness.
That's my viewpoint on it. But also we want these children to move. We want full range of movement in their neck. We want them to be free to play when they're on the floor during their awake windows. And these pillows restrict that. Same with baby containers.
So the ones that you put them in?
So a container is anything from a car seat to a baby beyond bouncer to these, they're not called sleepyheads anymore. Dockatots, they were rebranded because sleepyhead implied it is safe to sleep, and again, it's not. So the dockatots, what else do we have? We have the mamaroos. Anything that restricts a baby's movement that you're putting them in is a container. We want babies out of these. We want them on the floor for play. We want them doing tummy time, being held, baby carriers, and really limiting that container use to up to 2 hours a day, no more than 15 to 20 minutes at a time. So that is adding into the risk factors of plagiocephaly as well. That's why we're seeing increasing numbers, because a lot of babies are put in these containers and not even realizing actually it's restricting their movement.
Would you recommend sort of putting them in baby slings?
I do love baby carriers for a nice break. Just double check that the baby carrier that you've got is
the hip thing.
So you can check on the international hip. So
because some of them, they don't even, when the baby's awake, their heads aren't sort of, it's not restricted almost, like their heads are out, but it just gives you a bit more
so I would say if you're going out for walks and you can baby carry, try and alternate between the pram, because again, when on the pram, they're on the back of their head unless you're putting them in the tummy time, but they might not tolerate that for long. So just mixing it up a little bit, using a baby carrier is a nice way to have a relief of pressure on the back of their head.
Do you know, baby carriers were like a saving grace at my house.
Oh, they're amazing.
Both my kids, that's what we did for nap time. And to be honest, and then when the second one came around, I was able to kind of play with my big one with the little one in the carrier.
Exactly.
So it was the best thing.
They're brilliant. They're very good. They're
so
very good.
At least baby carriers, everybody take them out from containers.
Yes, please.
I
mean, I did a reel on Instagram about baby containers, and it was basically me saying, as a physio, I would never recommend them, but as a new mum that needed 5 minutes for a cup of tea,
absolutely.
I have a baby beyond bouncer. We do not use it very often, but maybe once a week for 10 minutes just so I can
at least quickly heat up your coffee.
Exactly. And
I think that's actually, it's good that you said that, because everything in moderation.
Definitely.
I mean, you're doing your best, and as long as they're not in there, like you said, for hours and hours and hours.
No.
To give you a little bit of time to sort of attend to your other child or eat something or use the bathroom.
Absolutely.
That's fine.
So up to 20 minutes. And then you've got how many 20 minutes or in an hour 3, so about 6 sessions of 20 minutes a day. That's what we're aiming for.
But definitely go down the baby carrier route
if you can.
And so obviously would that be ways to prevent it?
So
parents are probably now thinking, like, give me the good stuff, like how can I prevent it from happening?
So prevention, you can do a couple of things. Number one is for parents that are using the next to me co-sleepers. If you put your baby down, head facing you one night, then the next night alternate it so their feet are then by you and their head's the other way, because they're going to want to turn and look at you. So they'll turn to the right one night and then you flip them and they turn to the left the other night. And I say sometimes turn, so Sunday, Tuesday, Thursday, if you can remember that, head up on a Sunday, head up on a Tuesday, head up on a Thursday, and then your Wednesday, Friday and
Saturday,
one of them, then you're the other way around. So it's just a nice way to remember which way around did I have the baby last night.
That's actually a really good idea.
Yeah. So that's one tip. Okay. Another one is to really pay attention to how you're carrying your baby. So if you're right-handed and let's say you're bottle feeding, not breastfeeding, you're going to want to hold the bottle each feed with your dominant hand. It's easier.
Yeah.
So you've got the position, the head and the pressure coming through the same time every feed. So just remembering to alternate arms. And when you carry the baby, just alternating that arm, that can help to prevent as well.
That's so funny because when you're breastfeeding, you're naturally alternating as well.
Yeah. Ooh. So different breastfeeding positions. And then another way of preventing as well is obviously coming out of the containers, tummy time during the day. And just really looking out for those signs of head turn preference. And I always say to parents, go through your phone. We've got 1,000,001 pictures of our babies on our phones. Go through, and if you see every photo, your baby's looking to one way, you think, okay, I'm going to have a look at that, and I'm going to start to try and bring their attention over to the left when we're doing floor play. So these are all ways of preventing.
And then, of course, come and see you, should you.
Come and see me if you if you've got concerns. Yeah.
This one's a bit of a, maybe, I don't know, an out there question.
Sure.
Brain development.
Yes.
Is it affected?
So there is research, and not high quality research. I have to say this is an area that a lot more research is needed. There is some studies that are showing a correlation between babies that have plagiocephaly, and when they get to school age, they're scoring lower with their cognitive and their gross motor development assessments. Now, it's not a cause and effect relationship, so we can't say that the plagiocephaly is leading to these delays. It's very unlikely. What's more likely is that the child has got these delays, and that's actually why they've developed that plagiocephaly in the first place.
Got you.
Right. It's what we would say is a marker for being more aware and more of a reason to get these early referrals in from a paediatrician so that we can monitor and track these babies' gross motor development for any delays and any concerns, that we are on top of it, because early intervention is obviously the best. It leads to the best outcomes. So we want to see these kids earlier.
I totally get it, because if they're not rolling over or...
Right. And also if they've developed a plagiocephaly and they're spending most of their time looking to one side, that's going to have an impact on them achieving their gross motor, like rolling. Right. They're not going to want to turn and roll to the left if they're looking to the right the whole time. They might roll to one side, but rolling to the other side might be an issue for them. So it's all these things we need to think about.
Yeah, and it's definitely, it's well worth going in, for however long, an assessment is, 30 minutes, something like that?
Normally about 45 minutes to an hour for the first assessment, because I like to ask a lot of questions. I'm very thorough.
So let's say you've got a person comes in, what would they expect from an initial assessment?
So a lot of questions about pregnancy, about family history, and about what your typical day-to-day is with that baby. I'll be asking about containers, what you're using, things like how long is the baby in the car seat, what's your kind of day-to-day routine. And then I like to know what the concerns are, what the parents are actually wanting to achieve from physiotherapy, and if it is their goals are in line with what we can provide. Absolutely. I have parents that contact me a lot through Instagram, and they say, my baby's 7 months, 8 months, can I come and see you? And I'll say, at this stage, if it's for plagiocephaly, I can't, I'm not going to be effective, because your baby's most likely sitting at this stage, and I can't be effective with my repositioning program. So then I'll recommend that they go and have, if it's a moderate to severe and they've got real concerns, go and have a scan with an orthotist. So it's a light scanner. It's non-contact. I did a video on this recently. I took my little boy for a scan, and we took a video so that I could show parents what to expect from this appointment. So quick, so easy, and then it will give you all of the measurements of your child's head shape.
And they scan sort of around their heads?
So they put a little cap on, they put markers on, they'll do the scan, and then it comes up on the screen instantly, and they can go through the report with you. and they'll tell you if it's a mild, a moderate, and what their recommendations would be. Very unlikely that they're going to put you in a helmet if it's a mild plagiocephaly.
Yeah.
They shouldn't be.
No.
If they do, then I would be a bit concerned. But more moderate to severe, they will need a helmet to correct.
And that's for the older ones who've not gone through
That should be ideally started around 6 months.
Yeah.
And that's for the most effective. But they can put children in helmets up to 16, sometimes 18 months. But the more severe the plagiocephaly, the later you leave treatment with helmet therapy, the less kind of effective it's going to be.
It makes more sense. Like you said, these sutures, they kind of close.
They're starting to close. Yeah. The rate of growth has slowed down quite a lot. So early intervention.
That's it.
Follow your gut.
Absolutely. And that's the thing. There's always something niggling.
Yes.
You think, I should probably check that. Check that. And then something, you get distracted with something
else.
And
you're told, no, just wait and see. Just wait and see. Don't worry about it. Yeah. And that's just... It's not great advice. Yeah, it's not great advice. And as a parent, you say, that doesn't sit right with me. So go and this is the beauty of living in the Middle East. Absolutely. Go and get a second opinion. Absolutely. You're not stuck with that one doctor. You can go anywhere, shop around. Yeah. Or just come directly to an osteopath or to a physio. Yeah, absolutely. Yeah. There's a lot of professionals that are trained and can help you with this.
Yeah. Speaking of, what is the best way for people to reach out to you?
I am based at Neuropedia Children's Neuroscience Centre, so either directly through the clinic or on my Instagram page. I try my best to answer all my my DMs, and there's also an email button, so that will direct you to my email address, and I aim to get back to people within sort of 24 to 48 hours.
Perfect. So I'm going to link all of those, whether it's the clinic and your amazing Instagram page.
Thank you.
Yeah, so people can just shoot all their questions and make appointments. Now I feel like you'll get sort of a whole bunch of, I don't know, my baby's 2 months, I don't know, I think I see a flat spot.
I get a lot of pictures, and from funny angles, and I direct them to, I did a reel on how to take a photo from the bird's eye view that we were speaking about, so it's on there. I'll pin it up to the top. Just send me a picture if you've got any concerns, and I'll kind of say, that warrants an assessment, or it doesn't.
Brilliant.
Yeah.
Finally, I feel like that sort of wraps up everything. Also, sort of time wise, but with each interview, I started with a they say quote or statement, and I ended with the same, but from my wonderful guests. Yeah. Have you got one for us today?
I do. So I think it's quite aligned with the topic. Yeah. So prevention is the best form of treatment.
Absolutely.
And as we've learned from today, there are some preventable factors, and it's all about education, and that's what I'm trying to achieve. So feel free to come to one of the coffee mornings and meet me in person.
And you have those once a month? Or
we try to do them as often as possible. So every other week or every week goes up on the Instagram, and it's just lovely. A pop in. You just need to text and say I'm coming. As long as we've got enough space, we're happy to have people.
And it's quite nice to sort of get together with moms. And
it's definitely more of a social thing.
We all need it.
Yeah.
We all need it. Yeah. So, absolutely. Oh, brilliant. Thank you so much.
You're so welcome. It's been wonderful.
Thank you for coming on and sharing. And I feel like there's a lot of concern about flatheads. So I think this is going to be wonderful.
Amazing.
Thank you for taking the time out.
You're welcome.
Thank you for coming on. Thank you for listening to They Say It Takes a Village. I hope you enjoyed today's episode. I look forward to bringing you another one next week. Don't forget, please subscribe, rate, and review so I can reach and help even more parents. And if you've got a topic that you'd like me to cover, please head over to my Instagram page, ittakesavillage.me, and drop me a line.